Hello, everyone. Thank you for standing by and welcome to our webinar, The Family-Centered Cesarean Birth, sponsored by IsisParenting and presented by Dr. William Camann. My name is Nancy Holtzman. I'm the VP of Clinical Content and Online Learning here at IsisParenting. I'm also a mother-baby nurse specialist and board-certified lactation consultant. During tonight's presentation, all participants will be in a listen-only mode. However, you can submit questions to us at any time by typing them through the chat feature located to the left of your screen. We've incorporated many of the already submitted questions into tonight's presentation and will take additional questions at the end. This webinar is being recorded and you will receive a link to the recording by email tomorrow along with additional resources. So if you miss something or need to step away for any reason, that's okay. IsisParenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. Watch for our new centers opening this summer in the Dallas-Fort Worth and Atlanta areas. As I mentioned, I'm Nancy Holtzman and I'll be your moderator this evening. It's my pleasure to introduce our presenter for this evening, Dr. William Camann. Dr. Camann is the Director of Obstetric Anesthesia at the Brigham and Women's Hospital in Boston and an Associate Professor of Anesthesia at Harvard Medical School. Dr. Camann is an internationally recognized authority on obstetric anesthesia and pain control during childbirth. He has appeared on the Today Show with Katie Couric, the Mehmet Oz Show on Oprah.com, Good Morning America, and has been interviewed in the New York Times, Newsweek, Wall Street Journal, Fit Pregnancy, Pregnancy Magazine, and American Baby. Dr. Camann is the co-author of the book Easy Labor, Every Woman's Guide to Choosing Less Pain and More Joy During Childbirth. Easy Labor has won the 2006 Best Pregnancy and Childbirth Book of the Year from the National Association of Pregnancy and Parenting Books. It's my pleasure to welcome you this evening, Dr. Camann.
Good evening, and thank you, Nancy, and thank you, everyone, for having me here. It's a pleasure to be presenting this topic. It's one of my favorite topics. It's a fun topic and a new way of experiencing cesarean section, the so-called family-centered cesarean delivery. And as you can see in the picture here, which was a picture that I took myself during one of our recent cesarean sections, the baby has just been born, and we use clear surgical drapes so that the parents can watch the baby as soon as it's born, emerging from the uterus, and even interact in various ways with the baby as soon as it comes out. Here you can see the mother reaching up and touching the baby right through the clear drapes, and the advantage of an approach like this is it maintains a sterile surgical field, yet allowing the parents to interact both visually and physically with the baby. If we go to the next slide, this is an article that I recently published in one of the obstetric journals. It's OBG Management. This is a very nice journal. It can be reached at obgmanagement.com, and I believe a link will be provided to this in the information at the end of the webinar. It's all free. You can access all the content by just doing a quick free registration. But this article was published just last month by myself and Dr. Barbieri, who is our Chief of Obstetrics and Gynecology at Brigham and Women's Hospital. And we talked about all of the various things that we'll talk about tonight in this webinar. The concept of this was first introduced in the British literature. This was an article published in the British Journal of Obstetrics and Gynecology in 2008, the so-called natural cesarean, and then a newspaper article in the Times of London talking about the natural cesarean. Now, in fact, this is probably not the most appropriate term because it really is not natural in the sense that we think of natural childbirth. So the term natural cesarean is probably not appropriate. However, this has evolved into various terms such as the family-centered cesarean, like we're using tonight. Some people will call it the gentle cesarean. So it goes by a variety of different terms. Now, this question is a very important question. When could a family-centered approach be considered? Does this need to be planned in advance? In general, yes. One needs to remember that we are now in the infancy of this approach. Not everybody is doing it, and it does involve a multidisciplinary buy-in from obstetricians, nurses, pediatricians, and anesthesiologists. So as we are now in its early stages, it's not something that's available everywhere, and it sort of does need to be planned in advance at this time, but that's very institutionally dependent, depending on the resources and preferences of your particular hospital. The second point on the slide, the clinical situations where the family-centered approach would not be appropriate, and the answer is yes. Most notably, if there is an emergency situation, a problem where there's grave concern for the health of the fetus or the mother, these might not be appropriate situations. What gestational age would be considered is a very interesting question, because if you look at some of the early data on the concept of skin-to-skin contact to provide some of the advantages that we'll talk about in a few moments, the original research on this was done on premature babies. So while there's not one absolute gestational age cutoff where one either could or could not use this approach, it is interesting that the skin-to-skin approach, for example, for maintaining neonatal thermoregulation or temperature control, was first noted in premature babies. With regard to multiple gestations, such as twin births, as you'll see noted on the slide, it's absolutely appropriate for an elective scheduled twin birth. And I personally have done one at my hospital with a triplet birth, so it definitely can be done. Now the next slide, some of the aspects of this include some preparations that the anesthesiologist would be doing, such as placing some of the monitors in such a way that the mother would have a totally free arm. Some of the monitors include the oximeter, which is generally a little device that goes on the finger. In some cases, it could be put on the foot, as noted on this slide. But in general, what we try to do is keep all the monitors on one arm. So those monitors would be the oximeter, the intravenous line, and the blood pressure cuff. And if that's all in one arm, that will allow another arm to be totally free for the mother to interact with the baby. The EKG leads, or electrocardiogram leads, are usually placed on the mother's chest, but in an approach like this, we would put them either on the back or the side, or laterally, so the mother would have a completely free chest to be able to interact with the baby. The drapes during the birth, as noted in the picture earlier, are clear, as we use at Brigham and Women's, allowing the parents to watch the actual delivery of the birth. The slide says the drapes may be dropped, and that is an option for hospitals that don't have the clear drapes. However, that does bring up the issue of infection control, and that's always a concern with a cesarean delivery. After delivery, and what I mean by that is immediately after delivery, in the first few minutes, the early skin-to-skin contact on the mother's chest, or even on the father or partner, will help with things like neonatal thermoregulation. And we have done early skin-to-skin contact both with the mother and the father, and of course we have some pictures coming up of that in a few more slides. Breastfeeding is certainly possible in the operating room. It does get a little crowded up at the head of the table, especially with the surgical procedure still going on, but it certainly is possible to allow the mother to breastfeed in the operating room. The next point on the slide talks about delayed separation for routine care. There are certain routine things that are done in the operating room, such as certain injections to the baby, medications such as vitamin K, banding, such as putting on identification bands, and typically these are done at the neonatal area, which is away from the mother, away from the partner, and on the other side of the operating room from where the surgical procedure is taking place. But these, in fact, all these procedures can be done actually right on the chest of the mother. So there really does not need to be a delayed separation. And if desired by the family, the presence of a doula. We have had a number of cesarean deliveries at my hospital where doulas have been present and can be very helpful during these type of procedures. This just shows some pictures from the article that I presented earlier from the British Journal of Obstetric Gynecology. Of course, this will look better in a video, but what they're trying to show here in these pictures is a slower delivery from the uterus, trying to mimic some of the advantages of a vaginal type delivery. And this is dependent on the preferences of the actual delivering obstetrician. Now this slide, also from that same article, the original article describing the natural cesarean, shows the mother and the father watching the delivery of the baby. Now you'll notice that neither the mother nor the father are wearing masks. This was the picture that was in that particular journal article. Typically, the mother does not wear a mask, but everybody else in the operating room does. So although this slide shows a nice picture and a nice scene, this really would not be the way it's done in reality. The father would be wearing a mask, and at least the way it's done at my hospital, the Brigham and Women's, we would not drop the drape completely like that, which brings up the possibility of infection control. But rather we would use the clear surgical drape so the parents can still watch the actual delivery. Now this is a nice picture which shows early skin-to-skin contact, and it shows that it is absolutely possible to do this during a cesarean delivery, although it does, as I mentioned before, get a little crowded up at the surgical field and at the head of the bed. It certainly is possible to get the baby onto the mother's chest during these surgical procedures. Now this has attracted some attention of the media. I'll just show a couple of examples of some news stories using the term here, gentle cesarean, at this particular media outlet. There's another one using the term gentle cesarean. This is another term using gentle cesarean in Southwest Florida. So you can see the media in various outlets have picked up on this and are promoting this as a new approach, a new way to experience a cesarean birth. So these are some of the advantages that have been noted with early skin-to-skin contact: better neonatal thermoregulation or temperature control. And this has been shown initially in premature babies, but of course can be extended to term babies as well. Improved bonding, and we recognize it's hard to measure something as subjective as bonding, but certainly the impression of most people that go through these types of procedures is that this is an improved aspect of these procedures. Breastfeeding can be done in the operating room, or at least initiated early in the postoperative period. Glucose control is something that's important, especially in infants of diabetic mothers. They seem to maintain their sugar levels better when this type of approach is used. And of course, patients are very satisfied. And as we are doing this now more at Brigham and Women's, we are seeing nurse and obstetrician satisfaction as well. This may also be a marketing tool for hospitals to promote this type of really cutting-edge obstetrical care. So this slide shows a picture of a mother with the baby right up at the head of the bed. And this was taken literally within about 5 minutes after delivery. And the baby is up at the head of the bed on the mother's chest. If one looks carefully, you can see the surgical drapes just behind the baby, separating this whole scene off from the actual surgical field. But it does show that there is room up there to get the baby on the mother's chest, to have another pair of hands, such as in this picture, supporting the baby, the nurse's hand. So although it is a little bit crowded, it definitely can be done. And this is just another picture from my own hospital, again showing the baby, and this just shows the surgical field behind the baby. And you'll notice, if you look very carefully behind the white blankets on the baby, you'll notice that there's a blue surgical drape which separates the head of the bed from the surgical field. But if you look very carefully, you'll also see the clear surgical drape just behind that. And to give a little bit of background and more detail on how this is actually done, the parents do not actually watch the entire surgical procedure. We elevate both a blue or traditional standard surgical drape as well as the clear surgical drape. And then just a moment or so before delivery, we lower the blue drape so the parents can watch the actual infant emerge. And shortly after delivery, maybe 3, 4, 5 minutes later, we will then raise the blue drape again so they really can't see the rest of the surgical type procedure. Now, we have talked about the skin-to-skin contact with the mother, but in some cases, for various reasons, you cannot get the mother and the baby together. But certainly you can get the baby onto the father, and we have done this numerous times. And it does seem to offer some of the same benefits of getting the baby onto the mother's skin. Now here's some pictures. This was from a cesarean that we did at my hospital. And by the way, all the pictures that I'm showing tonight are presented with the permission of the particular patients that are shown, although I won't be mentioning any individual names. And in this particular set of 3 pictures, you can see first on the left, the nurse is giving the baby to the father, who has taken his shirt completely off in the operating room. The picture in the middle shows a nice example of the father cuddling up with the baby with a blanket around him. The woman in the background is a doula, and as I mentioned earlier, we have had numerous doulas who have been present in our cesarean deliveries. And then the picture on the right shows the father and the baby all cuddled up in a nice blanket scene. So this is absolutely possible in the operating room, and we do this quite frequently. This just shows another picture of the nurse handing the baby to the mother, and we're up at the head of the bed, so there's a fair amount of room to maneuver up there when one gets the father involved too, because then you are away from the actual surgical field. So as I mentioned before, the Brigham and Women's Hospital is really the only hospital that I know of that uses these clear surgical drapes for the purpose that we showed in some of the other pictures. And a number of questions have come through about where to get these. And I don't want to promote any one particular vendor, but I will just say that there are numerous vendors that make clear surgical drapes. They are often used in other areas of the hospital, for example, cardiac, orthopedic, vascular surgery. So it's possible that that your particular hospital may already have these clear surgical drapes in stock. But if not, as I mentioned, there's a variety of vendors that have these, and if you just Google clear surgical drapes, you'll be able to find a number of examples of where you can obtain these. And this is just a little letter that I published in one of the anesthesiology journals a few months ago, describing the use of these clear drapes for the so-called natural, or as I really prefer to call it, the family-centered cesarean delivery. And I'll just like to show you a couple of pictures now that we took at our hospital. And this just shows a baby. This has just been born, and literally seconds after birth, and you can see the baby being put up on the mother's chest by the obstetrician, and the mother is interacting with the baby with her hands, but it's through the drapes, so they're not actually interfering with the sterile surgical field. And this is just another picture, again, just seconds after delivery. And the question that's raised here is there's an increased risk of infection, and how is the baby passed to the mother while still maintaining a sterile field? Well, the baby is not actually physically passed to the mother, but the mother and the partner can interact with the baby through the drapes rather than actually reaching over into the surgical field. These are all sterile products. They're sterile surgical type quality materials such that they maintain the sterility of the surgical field. And that's why I feel that this is a better approach than actually lowering the drapes, which may then introduce the possibility of more infectious complications. And here you see just yet another picture of this. And the question that's asked here is, are there increased costs to this model of care? Well, the increased costs may be there, but they're minimal. The actual surgical drape itself really just costs a few dollars, so that's really nothing compared to the entire cost of a surgical procedure and a 4 or 5 day hospitalization. In many cases, though, the hospitals will provide an extra nurse. For example, at Brigham and Women's, we provide what we call a baby nurse. And this is an additional nurse on top of the actual circulating nurse in the operating room. And we understand that this may involve some increased resources. Many different hospitals could have different approaches to this with regard to the resources and the role and responsibility of the circulating nurse. So that really needs to be worked out on an individual case-by-case or hospital-by-hospital basis. But there may be, in some cases, increased resources required by having an extra or so-called baby nurse present in the operating room during these types of procedures. And this would, of course, free up some of the responsibilities of the surgical circulating nurse to do the more surgical or operative type duties of a circulating nurse allowing the baby nurse to focus on the baby, bringing it over to the mother, bringing it over to the dad or the partner, facilitating early skin-to-skin contact with either the mom or the partner, as well as facilitating early breastfeeding, even possibly in the operating room. Now, in this next slide, we ask the question, what can doulas do, and what's the doula's role in the operating room? Well, the doula can provide all sorts of support during a cesarean procedure. Remember that many mothers having cesarean deliveries are nervous, they are anxious, they need reassurance, and they need support. And although we try to provide this as the anesthesiologist or the baby nurse, we can help with providing this. If the mother has made an emotional connection or a bond with a doula through the various interactions prior to the surgery, then having a familiar face like this in the operating room can certainly help. You'll notice in this picture the doula is on the right side of the screen holding up a camera. Well, one nice role would be that the doula could be taking pictures, which allows both the mother and the partner to really focus on the birth and not worry about holding a camera and taking pictures. So if the doula takes a lot of pictures, then that frees up the family to really directly interact with the baby. One of my favorite tips about taking pictures in the delivery room is there's always a big clock up on the wall. If you notice in this slide, up in the upper part of the slide is a clock. And if you take a nice close-up picture of the clock right at the moment of delivery, that records the actual time of delivery, and that always looks great next to the baby's first picture to record that particular time. So I always tell the dads to look up there and take a picture right at the moment of delivery, and sometimes I'll even take the camera from the father or the partner and take that picture myself so they can focus on watching the baby. Now, this is a question that has come up very commonly in the questions which have been submitted tonight. How can I advocate for this at my facility? And this is an important question. This is a team approach. It needs buy-in from everybody, and that includes obstetrician, anesthesiologist, pediatrician, and nursing. And I don't think that any one particular person in any of those roles is going to be able to promote this concept. You really need a team buy-in from everybody. And I can tell you how this has evolved at Brigham and Women's is that a small core group of people, and that includes myself from anesthesiology, but also some obstetricians and nurses, have been promoting this. And I think one of the best ways to convince others is to actually show them. We have had a number of our obstetricians or nurses who may have been a little reluctant to embrace this type of model of care, but once they see how this can be done and what a nice experience it is, they really buy in. So you have to just show them, and I think that's much better than telling them. One thing I can tell you from being in an basically I spend all day, every day in operating rooms, most commonly cesarean delivery operating rooms, and there's often a lot of noise. People are chatting, and the fact is they're not always focusing on the mother. Sometimes they're chatting about what they had for dinner last night, or what the latest concert they went to, or one of their kids' sports events. And I hate to say this, but the fact is that's the reality of the situation is they don't always focus on the mother, who of course in a cesarean delivery is absolutely wide awake, unlike some other types of surgical procedures where the patient is anesthetized with a general anesthetic or a heavy sedative. So the mothers are absolutely wide awake, and I would like to emphasize the importance of everybody in the room keeping the conversation down to a minimum, focusing on the mother and her partner, letting them hear the sounds, such as the sounds of the baby crying and the various other sounds that go on related to the delivery. And I think one of the most important things that you can show people in the operating room is what a nice environment this is when everybody just remains quiet and focuses on the delivery. It really does change the entire atmosphere in the operating room. So this is an important thing, and you've just got to show people. That makes a much better impression than telling people. So for the patients, how can I speak to my providers about this? Well, one thing is just to basically simply ask if they've heard about this. Many providers maybe not. So one thing is just ask them if they've heard about it. You can show them some of the articles. For example, the article I mentioned earlier from the OBG Management Journal, that's a free journal. A link will be provided to that article as part of the materials at the end of this webinar. And a patient could certainly print that article out and bring it to their obstetrician and show them all of the details that are described in there. The question here on the slide, who would a mother first approach? I think the first approach would certainly be to the obstetrician. But then from there, requests can be made to the various nursing and anesthesiology personnel to consider this type of model of care. So some of these resources coming tomorrow will be in the electronic resources provided at the conclusion of this webinar, and everybody will be able to get access to these various materials. So I thank you for having me here, and I believe Nancy will have some more comments, and we have a lot of questions to answer, so we'll try to answer quite a few of the questions that have come through.
We do have so many questions. Many were submitted ahead of time, and we tried to work some of those into tonight's presentation, and then some have just been coming consistently throughout the talk. Some are rather technical. I think we have a clinical audience, which is great, as well as interested parents. Could you speak a little bit more about auto-resuscitation and the vaginal squeeze and benefits in terms of the baby's respiratory development, and whether or not there are actually improved clinical outcomes from this approach?
Sure. Well, we don't really know about improved clinical outcomes because we just don't have enough data on this yet. But this is really an obstetrical part of the procedure where they try to have the baby slowly emerge from the uterus to try to mimic some of the advantages of a vaginal squeeze with a vaginal delivery to get some of the fluid out of the baby's lungs. Now certainly coming out of an open uterus is different than the actual descent through the birth canal in a vaginal birth, so it's not exactly the same, but the theory here is to try to mimic some of those advantages with the surgical operative delivery.
Thank you. So some of the questions that we asked were how you can make the operating room a little bit more of a special place for the parents in terms of low lighting or music being played. Somebody asked about aromatherapy. It is an operating room, and the baby is born within the first 10 or 15 minutes, and then 45 minutes or so are spent taking care of business afterwards. But how can that time be spent a little bit in a warmer fashion?
Well, certainly the question about music is very common. We frequently have mothers bring music. They'll bring their iPods or various other electronic devices into the operating room, and some mothers that are particularly nervous that maybe don't want to hear some of the noises in the operating room can put in some earplugs and listen to music at various times so they don't have to hear some of the other events that go on in the operating room. With regard to lighting, that's a little bit more difficult. Remember, it is still an operating room, a surgical field, and of course the surgeons need to see what they're doing. So lowering the lights in the operating room is not really something that we're doing, although I think it could possibly technically be possible to keep the surgical lights on right at the surgical field and maybe lower some lights in other parts of the operating room, but the fact is that's not something that we are actively doing at my hospital. Another question was asked about aromatherapy. I'll have to admit that I have not yet seen that done in the operating room, and I think that there may potentially be a concern with various aromas and things like that in the operating room, but I just leave that as an open question. I really don't know how to approach that because I have not yet seen that type of an approach used during a cesarean delivery.
Thank you. Could you outline a little bit the highlights of the primary differences between a standard cesarean section, a routine procedure as it stands today, and some of these some of these variations that we've discussed this evening. In the private chats, I was talking a little bit about infant separation, and even if the baby, as we mentioned before going live tonight, doing a little bit of interaction and then sometimes the baby being taken to the table for 1 to 2 minutes and then being returned directly to mother skin to skin, not being swaddled and diapered, and routinely the baby is wrapped up and handed to dad who sits next to mom in the OR. But what are some of the primary differences?
Well, I think, as I mentioned before, just keeping the volume of conversation down in the operating room, so it doesn't really sound like a train station in there, which the fact is sometimes it does. We really do try to focus on the family and not on the other operative personnel that are in the operating room. As Nancy mentioned, getting the baby close to skin contact with either mother or dad as soon as possible, allowing the mother to watch as much of the birth as possible, depending on the availability of these clear drapes, or maybe even just lowering the drapes a little bit to maybe hold the baby up after delivery. Facilitating letting them play music during the operating room, certainly encouraging picture taking. I know that this is a bit controversial. There are some hospitals that have policies against videotaping in the operating room, and that's really a institution by institution decision, but I think almost every hospital allows cameras during delivery, and we should encourage this type of approach. So I think those are some of the main things that make this a bit different than the more typical cesarean delivery. And the other thing, as I mentioned earlier, was the placement of the various anesthesia monitors, which will allow the mother to have one totally free arm without any monitors or intravenous lines to allow interaction with the baby.
Excellent. Questions about how is the baby physically handed to mom while maintaining a sterile field, and then a separate question is how is the blue drape dropped? Is the baby handed to a sterile provider or a peds team and then to mom? How are these things physically done?
Sure. So this can be done different ways. In a typical cesarean, the baby is taken immediately after birth to a neonatal area, bassinet or resuscitation area, where the banding and various other things are done. But as I mentioned earlier, that can be done right on the mother's chest, or could be delayed a little bit. So, typically it is the circulating or baby nurse, or in some cases it could be one of the pediatric personnel, depending on the facilities of that particular hospital. And they will take the baby over to the mother. And remember that although the sterile part of the surgical field is the mother's abdomen, the chest is really not part of the sterile field. So getting the baby in there right above the drapes is where the baby will be placed. The technical question I think was asked, who actually lowers the drapes? That would, in almost all cases, be the anesthesiologist.
Okay, and then many questions about maintaining temperature, hypothermia, and at what temperature do you keep the ORs in these situations?
Well, this is also, I think, a very important question, because many surgical procedures are typically done in operating rooms which are very cold. If you talk to many people who have had surgical procedures other than cesarean deliveries, they'll tell you that one of the things they remember is just being so cold coming out of the operating room. In our typical cesarean operating rooms, we try to keep the temperature a little warmer, usually in the 68 to 72 degree range. But one place where we are particularly vigilant about this is in premature deliveries, because premature babies tend to lose their temperature much quicker than a term baby. So in these premature deliveries, we try to keep this room temperature up as high as tolerable by the rest of the surgical team. But remember that the evidence shows that keeping the baby on the mother or father's skin will also directly help with maintaining the temperature. So that's probably the single most important thing, even more important than actually keeping the operating room temperature up.
Excellent. What do you think are some of the most major obstacles to family-centered cesarean, and do you know of any professional organizations that are working on position papers to support this practice?
think probably some of the most significant obstacles are people are just hesitant about the whole practice. Many people in all areas of medicine, and it's not just obstetrics, are very set in their ways, having done things a certain way for a long time. And this is true of many people who have just done things the same way for a long time. Change comes hard, and it's difficult to introduce new concepts. But this is where one needs to, of course, keep an open mind and show people the advantages of this, and show them how nice it can be. I'll just tell you, in my own hospital, some of our more reluctant either obstetricians or nurses or anesthesiologists, once they see this, they'll say things like, "Wow, that's pretty cool." They really like it. So you just have to show them. The other part of that question was, are there any professional organizations working on practice or policy statements about this? At present, I don't believe so. But again, this is a relatively new concept, and eventually things such as ACOG, the American Congress of Obstetricians and Gynecologists, or AWHONN, which is AWHONN, which is the National Society for Obstetric and Neonatal Nurses, or AORN, which is the Association for Operating Room Nurses. These are the type of organizations that may eventually be issuing some statements along the lines of these practices.
Can you speak a little bit about how this may play out in larger hospitals, in smaller tertiary facilities, and in terms of situations where perhaps they may be able to do skin-to-skin in the OR, but in the recovery room there may not be staff to monitor the baby, or the baby may need to be separated and go to the nursery after a C-section?
Sure. Well, this is an interesting question, because routine practices really do vary tremendously based on the type of facility that the cesarean delivery is performed in. For example, some of these differences include whether the cesarean is done in a distinct obstetric operating room area, or whether it's done in the regular surgical or main operating room area, whether the baby stays with the parent throughout the entire surgical and recovery process. That's certainly the way it's done in most hospitals, but not every hospital. Now, what was the other part of that question?
Staffing in the recovery room.
Staffing in the recovery. So this is in some smaller hospitals, the surgical or recovery room staffing are regular recovery room nurses taking care of patients having other types of operations unrelated to obstetrics. And in situations like that, typically in some of these smaller hospitals, then introducing some obstetrical models of care like this may be a little bit more difficult than in a dedicated obstetrical hospital, where the recovery area is staffed only by obstetrical nurses who only take care of mothers and babies. So the type of facility is really important, and the type of staffing that goes on both in the operating and recovery areas is critical.
I'm curious if you have a sense of how many facilities across the country are practicing this type of care, and how a family might go about finding a provider or a birth facility that may use some of these types of models.
I wish I could give you numbers. There really, that data does not exist. It's, as I mentioned earlier, it's a relatively new concept. We don't really know how many hospitals are doing this, but I'm certainly encouraged by the number of people that are participating in an event like we're doing this evening. It does show there's a lot of interest out there, and certainly the most effective way to spread things like this is just is word of mouth. And this relates to the next question: is how do you get your provider, or how do you promote this to your provider? And again, word of mouth. If the provider has heard about it from other colleagues, then this helps. Showing them articles from the obstetrical literature helps, but basically word of mouth is the way these things spread most effectively.
Yes. Okay, well, I think we are almost at the end of our presentation, and as you mentioned, we will be providing resources tomorrow. So I've had a lot of questions about where people can learn more information about this. I'm going to send out an email tomorrow that will have a link to this recording so that you can watch it or share it with colleagues. or other interested people. I will give a link to Dr. Camann's recent article that we showed an excerpt from, and some information on VBAC, which of course is vaginal birth after cesarean, and then our cesarean birth e-class, which is a webinar similar to this that goes over basic cesarean information. And a lot of questions tonight about optimal cord clamp timing, and that's really a separate issue that we did not want to get into this evening, but we had Dr. Alan Green here at IsisParenting about 6 months ago, and we have a wonderful webinar that talks about that. So I want to thank everybody for participating this evening, and thank Dr. Bill Camann for being here and sharing valuable information with the audience, and thank you all for attending. And please do spread the word about this online learning opportunity, and I will send a link to additional webinars that you may be interested in as well. Thank you everyone. We hope to see you at another IsisParenting online event or in one of our centers sometime soon. Good night.